Good morning. It's a pleasure to be here, and I also want, since you're a talkative bunch and ask a lot of questions, I'm really happy that Eliseo Guayar, one of our associate editors for statistics, is in the room. So I'm going to give the talk, and Eliseo is going to answer the questions. So Kay asked me to cover a couple of things, so the talk is going to wander a little bit. Feel free to stop and ask questions whenever you want. But this is a brief overview of the topics I'm going to cover. I'm going to start with a brief overview of Annals' review process. The process at Annals, the process at every journal is a little bit different, and I think authors don't realize that, and give you a little bit of insight into what our process is at Annals, because it really is different than even the other, top-tier medical journals. And knowing what the process is, I think, may give you some insight into the type of review you get from Annals and what you might expect, which I hope will encourage you to submit, although I think sometimes it discourages people from submitting to Annals. I'll talk about a couple of surprises related to clinical trials that editors don't like. Some of these surprises relate to any type of study, but my assignment today was to focus on clinical trials. I'll also talk about editors' expectations when clinical trials get submitted to medical journals, and then talk about a few common mistakes in the analysis, reporting, and interpretation of clinical trials. I'm going to cover a few of the big ones that our statistical editors say are the things they find the most. This doesn't mean these are the only errors we find in clinical trials. Okay, so this is our process. This is part one of our process. So manuscripts come in, and we get about 3,500 of them a year. I or one of my colleagues takes a look at them and assigns them to a deputy editor and an associate editor. The deputy editors are full-time employees of the journal. The associate editors, and we're all sort of cross-trained. We're all internists except one who's a statistician. And the associate editors are in the various subspecialties of internal medicine. So Annals is an internal medicine journal. That's where our clinical focus is. So the associate editors will be, we have a cardiologist, an infectious disease doctor, and so on. So the papers get assigned to a deputy editor and an associate editor based on their content. The deputy editor and the associate editor review the manuscript, and they may decide to reject it or to send it for external review. About half of the papers are rejected just based on that review. But at this time, I've read the article, or one of the senior editors read the article, a deputy editor and associate editors read the article. So any article that gets rejected, even if it hasn't gone for external review, has been read by 3 people. The only exception, and it's an important one for clinical trials, is right here. When the manuscript comes in, we screen, and it's clinical trial, we screen for the registration. If it's not appropriately registered, we don't really even look at it, we just reject it. And this is, and that's important because even though clinical trials registration started in 2005, we get a good number of trials that are not appropriately registered, even from institutions like Hopkins and Harvard that should know about registration. If the papers go for external review, we try to get at least 2 external reviewers. We have a database with about 20,000 people in it who have agreed to review for the journal. In that database, we have people's contact information, their affiliations, and also their self-identified areas of expertise. The other important thing that we have is we have a history on them. So we know how many times they've reviewed, whether they've turned it in on time, and our associate editors grade the reviews. So we know people that we can reward people who do high-quality reviews with the pleasure of doing more free work for the journal. But we do try to avoid people who have not provided useful reviews because since we reject the overwhelming majority of papers that we get, the least we can do for authors is give them some good feedback. So in order to get 2 reviews, we usually have to ask 6 to 8 people to review. If we get more than 2 people who agree to review, we will take all the reviews that come in. When the paper comes back from review, the deputy editor and associate editor look at the paper again, look at the external reviews, and decide either to reject it or bring it to our manuscript conference. If it gets rejected up at this phase, it's a very short letter that really basically says it's issues of priority. At this point, people will get a letter that has a little bit more of an explanation, and they get the external reviews. When it goes to manuscript conference, this means that a group of about 15 to 20 of us read all the papers that go to manuscript conference. About 20% or 20% to maybe 30%, depending on the time of year, of the papers that go for external review will come to manuscript conference. The group at manuscript conference are largely our physician editors, although we always have one or two statisticians present at that meeting. The deputy editor who's handling the paper, the associate editor presents the paper, the deputy editor adds some comments, and then there's an open discussion, and we vote. The vote is not purely democratic. It sort of just gives us a barometer of what is more highly rated that day than other papers. And it really, when people ask what's the biggest factor related to a paper getting into annals, it really is the quality of the other papers that are being discussed at manuscript conference the week that your paper is discussed. So I always tell, this is a little secret, we get the most papers in July and August and between December and January. So if you want your paper to get submitted and have less competition, avoid July and August and December and January. It's just every year over the last 20 years, if you look at the graph, that's when the peak submissions are. So just odds are you're going to have a better chance of acceptance if you avoid those high demand months. After we vote, we decide, sometimes we don't vote, we just decide to reject, or we vote and then we decide to reject. At this point, authors get a more detailed letter, but not a lot of detail, and the external reviews, but they'll get some feedback from the discussion at our manuscript conference. If we decide to provisionally accept it, it's not over, because there's part two. And this part two is where Annals is different than the other journals. This is our statistical review process. So the provisionally accepted manuscript gets looked at by our deputy editor for statistics, Kathy Stack. She works full-time for the journal. Annals employs 9 different statisticians at various amounts of time. It equals about 4 or 4.5 full-time equivalents of statistical editors. So a lot of statistical person power at our journal. The deputy and each of the statisticians, they're cross-trained, but they have their areas of specialty. So we have people that do systematic reviews, people that do cost-effectiveness analysis, people that do trials, people that are good at really complicated epidemiology studies. And the statistical editor reviews the manuscript and then presents it at a second weekly conference, our statistical meeting. At the statistical meeting sometimes, even though the physician editors, we thought the paper was great, the statisticians identify flaws that make us just reject it at this point. If we think that it's fixable, they get a provisional acceptance letter, which includes a letter from the physician editor, a letter from the statistical reviewer, a letter from the external reviews. Now, what's different, the reason we have this conference is because before we had this conference, we found that the study statistician and the journal statistician were often at odds. And so what happens now is that the authors are not getting one person's opinion, they're getting consensus from this group. And we're also trying to have uniformity in what we ask authors to do. Because 10 years ago, there were some statistical editors that were sort of easier than others. So there wasn't uniformity in what we were asking people to do. When the revised manuscript comes in, the deputy editor and the statistician review it. If they think everything has been done, it gets accepted. If not, it goes back to the statistical meeting. And this little circle, our record is going around 8 times here. We don't like to do that. Usually there's 2 rounds of revision for complicated papers with complicated methods. And usually it's very unusual that after we provisionally accept something, we really try to work to make the paper suitable for publication. So once you've gotten to this point, rejection is unusual. It does happen. It's usually because the authors are refusing to do something that we think is absolutely essential. The 9 rounds of revision, a lot of times those are industry trials that came in showing that the new drug was fantastic, and we think that a proper analysis shows it's not so good. Those are the ones that kind of cycle around. Yes?
You have 2 boxes with provisionally accepted. So you have one in the upper left and then one in the lower right.
Right. So this is provisionally accepted after our content review.
So the authors haven't received.
No, the authors don't get anything until, and this phase is only, this doesn't happen obviously for papers that are not quantitative, commentaries and stuff. So this phase, the authors haven't gotten anything. We've just made a decision that we're provisionally accepting it, and then it goes through this cycle. Any other questions?
Yeah, so it appears that you can never get your article accepted the first time.
We have a quantitative paper. We've never accepted it without asking authors to do something. And that something may be just making the writing more clear. But it is, I can't remember. Even simple commentaries, we're giving some editorial, writing type suggestions.
Things have gotten really tough. or writers are getting lousy, I don't know.
Yeah, I
lived through a time when, in fact, you actually got articles
accepted first. Yeah,
they got some editorial treatment later in the process, but they were accepted.
Yeah, sometimes the list of things that authors have to do is relatively small. Sometimes it's not. Sometimes the list of things they have to do is longer than the original paper. Other questions? Okay, so a couple of surprises that editors hate. And this, again, is focused on clinical trials. Undisclosed conflicts of interest. We hate this with any type of paper, but also with trials. What happens, it's much better to disclose everything up front. When we find out about things or reviewers point out conflicts that were undisclosed, everybody gets suspicious about the paper, that somebody was trying to hide something. Just report the conflict of interest according to the journal rules that you're submitting to up front. If the journal is not specific about what conflicts are appropriate, a good resource is going to the International Committee of Medical Journal Editors website, icmje.org, looking at their conflict disclosure form, which is a little bit more comprehensive. It errs on the side of being more comprehensive than less comprehensive. So even if the journal doesn't require that form, if you've disclosed those types of relationships, you're pretty well covered. The other thing we don't like, of course, is inadequate IRB approval and consent. It's pretty atypical for trials that are done in the U.S. to be missing this component. As we get more trials from, global trials, unfortunately, a lot of times the article says nothing about this. And we've learned, rather than go through our whole process and then at the end find out there wasn't appropriate IRB approval or consent and not be able to publish it for that reason, we will start asking early on, did you just forget to mention this or did it really not happen? The next thing we don't like are authorship battles. So if you're involved in doing clinical trials, figure out the authorship up front. Editors don't like to hear about it. It's another thing that once people are battling about authorship, we're not in a position to say who should be an author and who shouldn't. We weren't there when the trial was done, and it starts raising all kinds of red flags. And you will have, sometimes where people just, getting involved in those battles is too much of a problem. It's not worth publishing the trial. So it really can affect the publication of the trial. And then the last thing is undisclosed related or planned articles. And I'll talk a little bit about this other one. So the types of related articles that editors want to know about with clinical trials. Previously published articles from the same trial. They should be cited or at least noted in the cover letter. We don't like when there have been previous analyses and we don't know that. Annals publish lots of secondary analyses of the very big drug trials that are in New England Journal and Lancet. And it's really surprising how many times, usually we know that it's been, the primary report has been published, but sometimes they don't tell us that. And again, leaves a bad taste in your mouth when you find out, you have to dig for where the primary results were. In-process articles using data from the same trial. We need to know about this, and it is perfectly fine, the editors of the journals where those are in process, we treat those confidentially, send drafts of those in-process papers, whether they're submitted to a journal and under review or they're about to be submitted. We really don't like finding out about those things in the middle, and you'll avoid the situation where we're asking you to do things that you're intending to report in another paper. and then planned future analyses. They should be noted in the text or in the cover letter. Sometimes you don't know that you're doing these analyses, but I'll give you an example. A couple of months ago, we published a clinical trial that was looking at treatment of hepatitis C in hemodialysis patients. And this trial looked at patients with one genotype of the virus. After we published that paper, we got a second paper that was exactly the same, but it was in genotype 2. But it was the same trial where the patients had been randomized. We went back to the registration. It wasn't clear that they were going to do it in these two different genetic groups, and there was no mention in the first paper of the second paper or the second paper of the first paper. So that pretty much, it made us rethink our choice about publishing the paper we had already published, and it certainly made us not interested in the second analysis. Whereas if we had known about it and they provided a good rationale, it might have been different. Any questions about these surprises that editors don't like? I think this is...
Well, the second one, in process articles, I mean, I've frequently had, because they cover different issues entirely, like 2 manuscripts and one to one journal, one to another journal. Right? You would expect me to send you both and just let you know that one is... I mean, I've never seen that as a requirement.
Editors will expect that, to know about other stuff that's there, and we won't, it's confidential. We won't send that other manuscript to our reviewers, but we want to know what's there because we want to prevent overlapping publications or publications from the same trial that are using different methods inappropriately. So we do want to know about them, and it's always better to know about them up front than find out about them later. And we often find out about them. It's surprising, but somebody will say, well, I thought I was reviewing, one of the external reviewers will say, I reviewed a very similar paper for another journal, and so we do find out about them.
And is that in your instructions?
Okay, so some additional expectations when randomized controlled articles reporting randomized controlled trials get submitted for peer review. As I mentioned before, we expect trial registration. The trial registration policy should be registered before the first patient is enrolled. It applies to clustered designs. It applies to any intervention that's looking at an effect in patients. So if it's an effect that's looking at maybe knowledge outcomes in physicians, some journals don't think that applies to the clinical trials registration policy, but it doesn't really matter whether you're looking at a diet intervention, a behavioral intervention, a drug, a device, a surgical procedure. And as I said, even 7-8 years after the institution of that policy, we still get trials from big U.S. institutions that are not appropriately registered. And as a matter of fact, a couple of weeks ago, what we started to do is send letters to the IRB at that institution saying, look, we were unable to publish this trial from your faculty because it wasn't appropriately registered. It might be good if you put this on your checklist for IRB approval to remind people. Because it's usually not people who do a lot of trials, it's physician investigators who may do 1 or 2 trials and just are not linked into this community and don't know. So it seems that the IRB might be a good point to make that happen. The other thing we expect with randomized trials is to have access to the protocol and amendments. We ask authors to submit this when they submit the article. If they don't put it in at that time, we do ask for it by the time it gets to that provisional acceptance. We ask for the protocol and any amendments that happened. We do get it where this gets a little bit hairy is when the trial has been done outside of the U.S. and the protocol is only available in Dutch. If the protocol is in Spanish or French, we can translate it. If it's in Dutch or Arabic, we have more problems with that. So that I think increasingly there may be a time where the expectation is that there will at least be a protocol summary in a language that's more universal. Yes?
Related to that second bullet, how do you handle the situation where there are methods made for the changes since the protocol that aren't documented in methods, things like primary outcome changes and stuff?
Yeah, I mean, we consider that, and then, it's part of our judgment about whether that amendment change was reasonable, or was it done just because they didn't see that there was going to be a significant result in the initially defined primary endpoint? So the information, there being amendments doesn't mean that there was any problem, but it's, again, knowing the history of when things changed and why is helpful during the review process. Okay. The other thing that we expect with a clinical trial, and actually even with observational studies, is if during our review process we think that we need access to data or to the statistical code, we expect that authors will provide that. Now, this is not saying that we're going to make that publicly available or we're going to share it with external reviewers, but we might need it for our internal review process, and if authors refuse to give us that, usually we would reject the paper at that point. Okay?
Well, related to this, do you have a policy, given the open access to trial data that's happening, if somebody submits an article using somebody else's data, another trial data set?
Our policy as far as data availability, so in 2007 we instituted a reproducible research policy. And what that policy is that every published paper has to say whether the authors would agree to make the data, the protocol, and the statistical code available to interested readers, and what the circumstances of that are. So we're not requiring that they do it, but we're requiring that they say in the paper whether or not they would. So if they say they would, and somebody has problems getting the data, we say, you promised it, you're not holding up to that, and we would publish a correction or a notice in the journal that says, although these authors said they'd make the data available, people asked and they couldn't get their hands on it.
But I mean, what if I'm the author of a paper using open access data? I didn't do the trial myself.
Well, I think in that case, then your reproducible research statement would say the data are available to you the same way they were available to us at this website. But we do think I think in the data sharing arena, things are rapidly evolving, and I expect our policies will rapidly evolve to keep up. The other thing, and asking for the statistical code and the data most often happens in a situation that LSAO describes as the paper is too good to be true, or the paper is too happy. And in those circumstances where things just don't seem possible might be. The other circumstances we really can't understand from their statistical analysis section what they did, and our statisticians will look at the code, and in a few minutes we'll have a lot of clarity about exactly what the authors did. And then the last thing is we expect people to follow the consort format in general. I think consort, as it expands, to follow all the millions of things, but generally the checklist is something, and certainly consort flow diagrams are something that we expect. Any questions about this? Okay, now moving on to the area where I might need to call on LSAO more, because I'm getting more into the methodologic realm. So common mistakes in reporting of RCTs. We see misuse of intent to treat terminology. We see inadequate reporting of harms, inadequate handling of missing data, and this third thing is a real biggie. Very few papers come in where missing data, there are no issues with the handling of missing data. And then something that kind of summarizes these other three things is a failure to recognize when trial data really needs to be handled like observational data. Because even though it comes from a trial, the situations have made the data that's being presented in this, to answer this question, observational in nature. Okay, so this audience knows all this, but I'll run through it quickly. Intent to treat, analyze as randomized. It means including all randomized patients in the analysis, regardless of whether they started treatment, received the assigned treatment, met all inclusion criteria, adhered to therapy, whatever. So if there are protocol violations, as people were randomized, that's how you're analyzing them. You're retaining that original randomized assignment in all of the analyses. Why adhere to it? Well, it preserves the integrity of the randomization, and it reduces the potential for bias. And the thought is that it provides pragmatic estimates of the benefits of a treatment policy or a strategy rather than an estimate of benefit of the actual drug. It's sort of the strategy of prescribing that drug. But there are some problems. Despite best intentions, strict adherence to intent to treat isn't easy. There's non-adherence, there are missing outcomes, there's dropout, and sometimes by adhering to intent to treat analyses, you're missing the opportunity to answer some questions that are really important to clinicians. Yet many RCT reports state that the intention to treat analysis was conducted. So I'll give an example of this. In some of the early trials of zidovudine for HIV, there was a trial that compared high-dose zidovudine to low-dose zidovudine, and it looked like there was a benefit of the low dose. But actually, what was happening in there is that many more patients in the low-dose group, for whatever reason, were getting prophylaxis for pneumocystis pneumonia. It wasn't part of the protocol. It just happened that more patients. And when there was a deeper analysis that wasn't an intent to treat analysis, it became clear that the benefit wasn't the low-dose drug. The benefit was this co-therapy that just for whatever reason people in that group happened to be getting more of. So doing an intent to treat analysis there without going down and looking into the messiness that happened during the trial was going to lose the opportunity to answer an important clinical question and would actually give clinicians information about the effectiveness of the low-dose drug. But ITT has become a buzzword. Other buzzwords, modified intent to treat analysis, so this usually means restricting the analysis to people who had at least one dose of the treatment and had at least one baseline follow-up. Per protocol, restrict the analysis only to those patients who followed the protocol strictly, as treated, treatment received rather than randomized treatment. So regardless of what group was in, if the patient took the drug, you analyze in that way. And what our statisticians want people to move away from, and the consort group wants people to move away from using intent to treat as a buzzword. While the principles of intent to treat are good in some cases, what's much more informative to the reader and the clinicians and policymakers that are trying to make decisions based on this is a clear description of who was included in the analysis and why, and whether those people had initially been assigned to one treatment or the other. So from the consort checklist, item 6 in the results says for each group, number of participants, the denominator included in each analysis, and whether the analysis was by original assigned groups. And the most recent consort update from 2010 says that in the consort checklist, we have dropped the specific request for intent to treat analysis in favor of a clear description of exactly who is included in each analysis. So again, sometimes intent to treat, people who are looking at trials and may not be as sophisticated as this group, they say intent to treat, check mark, that's good, and move on without digging deeper and seeing some of the messiness that can happen that makes an intent to treat analysis not really answering the questions that people need the answers to. Okay. Any questions about this? Any misinformation I've given, Elisea? Okay, reporting harms. We see a lot of problems with reporting harms in clinical trials. And the common problems are people have vague summary statements about adverse events. So avoid vague summary statements about adverse events. Avoid declarations of safety unless the trial is truly adequately powered to detect harms, and few trials really are. And recognize which adverse events people will be most interested in and discuss them specifically. So what we see a lot is there's a long list of adverse events. They'll say there was no difference in adverse events, but there really was a big difference in nausea, and that's what people really care about. Talk about the specific one if there was a difference in that, even though when you add them all together, everything washed out and there wasn't a difference in adverse events. And avoid including the same event as both an effectiveness outcome and a harm. And this is something funny that we've been seeing a lot in the rheumatology trials. So people are assigned to one drug versus another for their arthritis. And an improvement in their arthritis score is their outcome of interest. But when you look in the adverse events, failure to improve your arthritis score is also included in adverse event. So that outcome is included both as an effectiveness and a harm, and it creates funny, unusual things, and it's often very useful in people that want to make a safety claim, because when you include worsening arthritis in the adverse events, when you add all the adverse events together, it looks like there is no difference. Yes?
I don't know how you avoid that. And I don't think it's just restricted to rheumatology.
Yeah. I mean,
MI, that's the outcome. You're trying to reduce it, but it's also cause of hospitalization, which is by definition an SAE. I have problems with the SAE categories, but it's one of those where I just don't see how you can.
Well, I think in some instances you wouldn't want to include MI in that occasion, but MI might be among the reasons for hospitalizations, and then you'd want to explain that, but you wouldn't want to have MI defined the same way as both an adverse event and an efficacy outcome, because it should be, if you're talking about it as an effectiveness outcome, you're going to see that effect there. So it creates, again, it's the most important thing is clarity about what you've done and how you've handled it. And if you are including the outcome as both a harm and a efficacy outpoint, to explain why and the messiness behind that. And you're right, it isn't only the rheumatology trials. We have seen that a lot, though, in some of the rheumatology trials that we've gotten recently. Are there questions? So this is an example of a RCT of exenatide in people with suboptimally controlled type 2 diabetes. And in the trial, it randomized 121 people to subcutaneous exenatide twice a day. Placebo group got subcutaneous placebo 2 times a day, and then the other group, exenatide or placebo, was added to people that were already on a thioliazidine drug, and some of these people had metformin or not. This is an example, I'm sorry, it's probably too small to see, but what we thought was a good way to report adverse events. And this wasn't, unfortunately, the way the initial paper came in reporting the adverse events. It just had something saying that there wasn't any difference in serious adverse events between the two groups, but you can see that when you look down, this is an example, this is nausea here. There was quite a big difference in nausea. There was a difference in hypoglycemia, and there was a difference in vomiting. So while you lump them all together, there wasn't a difference, but patients who are taking this drug complain a lot about nausea and vomiting, and there are some problems with hypoglycemia. So those are the adverse events that clinicians want to know about. So it's really important to report them out separately. And this is just an example of that in the abstract, including the adverse event information in the abstract, because often that's what clinicians will read and they won't go any further. In this example, 16% of patients in the exenatide group and 2% in the placebo group discontinued treatment because of an adverse event. In the exenatide group, 40% of patients experienced nausea and 11% experienced hypoglycemia. And then in the placebo group, those same numbers. So again, picking out the adverse events that are most clinically important and reporting them specifically, avoiding sort of these global statements about no difference in adverse events without some explication of the things that were included in there, and without a statement about whether or not you really had any power to detect those events. Any questions? Okay, the next problem is missing data, and I would say this is the thing that we talk, probably the topic that consumes the most time at our statistical conferences. Why do people have missing data? Lots of reasons. Loss to follow-up, crossover, mixing of study treatments due to rescue therapy, co-interventions, non-adherence, the timing of randomization. And a lot of times what people don't, in trials that are longitudinal and you have multiple follow-up over time, even though they may have accounted for a lot of, almost all of the patients at the end of the trial. There can be a lot of missing data in those interim measurements, and oftentimes people don't talk about those missing variables or missing covariates, missing interim outpoint. They're just talking about the number of patients that came in for that final outcome measurement. Again, sources of missing data can come at any point in the trial. You can have the eligible population and non-response, refusals to participate, or people never show up for required assessments. This creates sampling bias. Once people are enrolled in the trial, you can have missing data on endpoints or covariates, like I mentioned, dropout due to loss to follow-up, an adverse event, a death, worsening disease, and also missing data on the interim endpoints. And this sort of missingness causes biased effect estimates and overestimates precision if not handled appropriately. So the steps to follow with missing data. Number one, recognize that it's missing and tell the reader that it's missing. You can't handle it well if you don't really understand the extent of the issue. Second, explore the reasons why it's missing. What's the mechanism behind the missingness? And then try to decide, using Rubin's taxonomy, whether it's missing completely at random, or not at random at all. And I'll talk more about that taxonomy in a minute. And then select an appropriate analysis to handle the situation of the missing data. The goal should be to give you as unbiased as possible estimates with correct estimates of variability. And then when there's a substantial amount of missing data, you're always in an area where sensitivity analyses are going to be warranted, at least when you submit your trial to annals. You can expect that we'll be asking for those sensitivity analyses. So again, the taxonomy for missing data. Missing completely at random. This means that the missingness is not related to any observed or unobserved data. So this is technician errors or equipment malfunctions, a staff member mistakenly forgets to administer a questionnaire, sort of these kinds of events that are likely to be completely at random. Now the trick is making these determinations often depends on unobserved data, and we don't observe it. So you're really just trying to imagine the conditions that might be at play. Missing at random means that the missingness is related to observed data but not to unobserved outcome. So it's non-informative missing. So an example of this is you're missing post-baseline quality of life, more common in individuals who started out with a low baseline quality of life. Or dropout was more common in younger participants than older participants, but it's not really related. You don't think it's really related to the outcome. And then missing not at random is informative missing, where it's related to unobserved outcomes. So the patients who are too ill to attend a visit and complete assessments are the ones that are not following up, or patients' conditions worsen and they need rescue surgical intervention, and the missingness is caused to that. So the missingness is related to the outcome of interest. A hypothetical example. So another trial in type 2 diabetes. People are assigned to intervention or no intervention. The measurements of covariates include age, gender, years with diabetes, things like that, and the outcome assessment is hemoglobin A1C at 0, 12, and 24 weeks. The trial is done at 24 weeks. The hemoglobin A1C measurement is missing in 20% of patients. You have to dig deeper to be able to analyze it appropriately. So if it were missing completely at random, it would mean that missing hemoglobin A1C value is not associated with any observed or unobserved data. How can you get a handle on that? Well, you'd be looking at things like there isn't more missing in those who had high baseline A1Cs. There's not more missing in those at one site versus another trial site. And there's not more missing in those who have a higher 24-week A1C than those that had lower. But this last one is tricky because you really need a crystal ball to be able to know whether those people are missing at that point in time. Another, missing at random, how could you maybe think that these assumptions are the right ones for your analysis? So this means that missing A1C data at 24 weeks is associated with some observed data, but not with the unobserved data, so not with the 24-week A1C. So there's more missing in those that had more missingness among those that had high baseline A1C, and more missing in people at one site than another site. But there isn't more missing in those with a higher 24-week hemoglobin A1C. But again, this last point, you need a crystal ball to be able to tell that. So what these examples are intended to do is that you can never be completely sure about these assumptions about the missingness, but you can look at some things that start to give you a handle. And this last one, the unobserved data, you're really just talking about what's likely, given likely and reasonable, given what you know. So missing in this trial, if it was missing not at random, would mean that the hemoglobin A1C at 24 weeks was related to the unobserved value and may also be related to observed data. So this means that there definitely was more missing data in those with higher 24-week hemoglobin A1Cs. And this would be a situation, and I guess where you might get a handle of this, if the people who are all missing were people who were hospitalized with DKA. You may not have their hemoglobin A1C value, but it might be that you could assume that it wasn't good if they were hospitalized with DKA. So once you've made some assumptions about what kind of missingness you have, you can try to match the analysis to the missingness. So if it's missing completely at random, more methods are viewed as appropriate, even a complete case analysis if the extent of the missingness is small, so, under 10%, small amounts of missingness. But it's a big caution to make that assumption and do a complete case analysis with no sensitivity analysis, because it's a very strong assumption and it often doesn't hold. So you will be, unless there's a very small amount of missing data, you may be skating on thin ice to do this sort of an analysis. If it's missing at random, some methods that might be appropriate are multiple imputation, mixed effects models, weighted generalized estimated equations. So more complicated modeling, and there are resources that I will point to later, some references that go into this in more detail. But any of these methods, you're also going to have to do sensitivity analyses, because again, you're basing them on assumptions and you're not quite sure about whether these assumptions are right. And so sensitivity analyses are always going to be warranted. If it's missing, yeah.
For the multiple imputation, is that imputing the covariance, or is that imputing the outcomes?
You're taking the observed data that you have, and then you're imputing the outcomes that you were unable to observe. Is that? When you know that the missingness is not at random, usually you're in a situation where you're doing best, worst case sensitivity analyses with things that I can tell you what the names are but couldn't do myself. So pattern mixture, shared parameter, and joint modeling. And it's usually a suite of sensitivity analyses that you're presenting in the results section to try to get some information out of this trial where missing data was a problem. These models can be very challenging. They should not be done without a statistician's help. Inference relies on untestable assumptions about the distribution for the missing data, and the results will be sensitive to unverifiable modeling assumptions. So you need lots of sensitivity analyses and lots of talking and writing to assure the reader that what you found is reasonable. This is what people usually do, though, for missing data. This is a trial of weight loss, where they're measuring body mass index over 12 months in a drug trial. And what you see, there are lots of reasons for missing. This patient had an adverse event, and they went missing. This patient moved out of town, and they went missing. And this patient stopped the trial because they were unhappy with their weight loss. But what people usually do is last observation carried forward. So they're assuming that all these people who were missing, for a variety of reasons, had the same value going forward. So it understates the variability, it results in bias, the direction of the bias is unpredictable, and there are better methods that exist. So although there are lots of trials that have used last observation carried forward, although there are lots of trial protocols that specify this is how they're going to handle missing data, this might be okay if there wasn't very much of it, but once you know how much missing data that you are, even if it's in your protocol that this is how you're handling it, it's not a very it's a contemporary standard way of dealing with missing data. So this is another weight loss trial, low-carb diet, low-fat diet. The endpoint was body weight at 24 months. There were study assessments at 3, 6, 12, and 24 months. And you can't read the details on this consort diagram, but you can see that as you went on, there started to be a lot more missingness. And by the end of the trial, you're missing 32% in one group, 42% in the other group. 42% was a low carbohydrate diet, which was the diet of interest in the study. So something had to be done to deal with this level of missingness. And what the authors didn't do in the first submission, but what they were pushed to do and educated on how to do during the review process, was to use a random effects linear model, all observed data. So they're using this modeling, and then they are doing sensitivity analyses too. So initially it just came in, last observation carried forward, but you're carrying forward an awful lot of observations when you've lost 42% of your people in your trial. So more sophisticated methods, and this trial was salvageable and presented some clinical information, although could not be as definitive had there been appropriate follow-up.
So did they not do multiple imputation for their 24-week?
They did do what? They did do multiple imputation, right? No, this one. No, what? Okay. And then this is another example. This is a trial of glucosamine in patients with hip osteoarthritis, and the missingness in this study. People were randomized to glucosamine or placebo. The primary outcome was an arthritis pain score and functioning over 24 months and joint narrowing over 24 months. They collected this data at 3, 12, and 24 months. But there was a problem because this is a consort diagram, and you see that 6 patients in this group and 12 patients in this group had total hip arthroplasty. So they had co-interventions. The co-interventions were not balanced between groups. So what these researchers needed to do is handle this kind of sloppiness in their clinical trial. And what they did was they used linear mixed models to analyze the data, assuming that the data were missing at random. So they made that assumption. For patients that had total hip arthroplasty during the trial, we included observed data before surgery in the analysis and assumed that data after the surgery were missing. And for patients who were lost to follow-up, we included all observed data in the analysis. And then to explore the validity of the missing data assumption for patients who underwent surgery during this study, they did a sensitivity analysis on the WOMAC pain data. The WOMAC is an arthritis score. And then just shows the variety of sensitivity analysis they did, assuming traditional best case, traditional worst case, and a variety of assumptions in between. And because they found that the robustness of the results in these variety of sensitivity analysis gave you, the reader, more confidence in the assumptions about the effectiveness of glucosamine. It wasn't effective. Anybody wants the bottom line? And these are just the results of the variety of the sensitivity analyses. And again, this is just saying how they reported it in the trial, and it was really important that even in the abstract, they said that 20 patients had hip replacement during the surgery. So it wasn't something, this limitation was important, and it wasn't something that people had to dig deep down into the results section to find out. And then this is a useful reference for people who are trying to look at some of the details about the methods for handling missing data. It's from the National Research Council, 2010 publication, and it's available for free online at that address. And I will leave these slides with Kay so people can have that. And then in our information for authors, we do have a little bit of information, and then we link to these references, but we do say that we really don't like last observation, best observation carried forward, and that people should really be doing more sophisticated methods for dealing with missing data when missing data is a problem. So missing data in some, aim to avoid it, but if it happens, realize that the comparisons are subject to bias, use analytic methods that are likely to give you less biased estimates. The validity of the results will depend to assumptions that you make about the missingness, and most assumptions are untestable, so you're going to be in a situation where you need to do sensitivity analyses. Now this last part, and we're running out of time, but kind of sums up some of these issues.
One question, I think, and you touched on this, but I think because many of the things that we ask investigators to do conflict with their protocols. And
right.
This issue of and this is a sort of contention that we often have, and we tend to even if they have something in their protocols that we don't like, we make them change themselves.
Right, and we will in that situation. So again, so the protocol says if we have missing data, we're going to carry that last observation forward. And the authors will say, well, you're asking us to do something, and it's going to violate our protocol. And then we'll get into a tussle with them and say, but your protocol didn't, when you designed this trial, maybe you didn't realize you were going to lose 40% of the patients in the intervention group. So we do let authors report what was in the protocol, say that this analysis wasn't in the protocol, but given the extent of missing data, we thought that it was more appropriate. But a lot of times we have people saying, you're asking me to violate my protocol, and viewing that as a crime. But it is. I mean, when you design the study, you're pretty optimistic that you're not going to be missing all this data. But still, I would say that given that these other methods exist, people shouldn't be putting last observation carried forward in the protocol, particularly in situations like, trials of weight loss drugs where that follow-up is going to be problematic. Okay, so the other issue that is kind of more global issue that involves some of the other things that I've talked about is the failure of people who are reporting trials to recognize when RCT data really needs to be handled as observational data. And randomization prevents baseline confounding and selection bias, but it doesn't protect against post-randomization confounding and selection bias. And intent-to-treat analyses are insufficient to deal with post-randomization, confounding, and selection bias. Where does this happen? It happens in trials examining the effects of sustained interventions over long duration in typical patients in typical care settings. So pragmatic trials, large, simple trials are some of the buzzwords that are used to find these trials. It doesn't happen in phase 2 trials that are looking at drug efficacy, and they're a month long, so nobody is lost, and it's a very controlled, tight situation. But in these pragmatic trials, you'll have non-adherence, you have crossover, you have dropout, you have differential use of concomitant therapies. So you need to deal with it. And a very nice article that expresses these ideas by Miguel Hernan and colleagues that we published in October, and what Dr. Hernan says that starts out by saying, despite what you may have heard, randomized trials are not always free of bias and confounding. And the description of, he points out that descriptions of lots of pragmatic trials could also fit an observational study if you just replace the words are randomly assigned to with decide to take. And that what started as a randomized trial may effectively become an observational study that requires analytic analyses to and go beyond the intent to treat analyses. This is a very short article, but very informative. I really encourage people to take a look at it. So what are some of the situations that fall into this category? This is a hypothetical study of an intervention for a fungal infection. So you have patients who have probable infection. These are sick people. They're on cancer chemotherapy. They're neutropenic. And they get and something has to be done. You can't wait to confirm whether they have this fungal infection. So the cultures are done, the tests are in the lab, but you have to do something. So people are randomized at this point to the control intervention or the new drug. But what happens is at this point in time, the culture results come back, and you find out that these people didn't really have the infection of interest. Only these people did, and those are the only people that you want to include in the analysis. So can you just analyze these groups as though they were randomized? You shouldn't. Another situation, this is a trial of doxycycline to stabilize abdominal aortic aneurysm that we published a few months ago. And the problem here, why they couldn't do a simple intent to treat analysis, was elective surgery. 22 patients in this group, 21 patients in this group of about 140 that were assigned in each group went on to have elective surgery during this period, so they couldn't have the outcome assessments to see whether the doxycycline decreased the growth of their AAA.
Could you go back to the one before that, John? Yeah, that one. So how would you say you should do that analysis at the end?
I'll go on.
You don't think that just doing it as a randomized analysis would work, since presumably, if the randomization worked, the likelihood of a positive or negative diagnosis should be the same in the two groups.
If the randomization worked.
But if you had a real randomization and then, there's no reason to suspect that there was a bias on one side or the other, they ought to come out the same.
I think
If you saw at the end that there was a huge difference, I could see that. But
one thing, and I may ask Alcea to bail me out here, but one thing you couldn't do is not adjusting for any of the covariates here.
you'd have to.
Yeah, the same way
You only
maybe.
do it on those who are included in it. You don't even include those who are positive.
Well, you include those who are positive, but you also want to know were there people who had different levels of neutropenia in these two groups, or was there different cancers that were in this group? Was there something different about the people in these groups? Even though these groups were similar, did you retain the similarity in covariates between these groups? So you would, at a minimum, have to look for that. Alceo?
And one problem is that if you do that, the efficacy is going to depend on the proportion of people that really have the disease. Which
You look at that and you just,
Yeah, so.
Yeah, but
if the randomization was holding, there'd be no, if these things were truly randomized and therefore they were about the same in both groups. Why would there be any problem treating as a randomized trial for those who were included because, and only because they had a positive diagnosis? The exclusions are only because they had a negative diagnosis.
So
Yeah, but I think it depends on what is the question you're looking into.
I wonder whether the treatment benefited people who got a positive diagnosis.
But the other thing would be that what you wanted to, particularly if there were a problem with adverse events, since these people got the drug too, if you were looking at sort of safety of the strategy of randomizing before you have something back, you wouldn't want to exclude these people in red from the safety analysis. You'd want to include them. So you do have to really think about this funny thing that happened here in the questions you want to answer. And certainly for the safety analysis, just excluding these people wouldn't be the right thing to do in this case.
But doesn't it depend on what they know when they exclude? I mean, if they exclude the excluders, the people who do the exclusion or inclusion are masked, blinded, or whatever to randomization, that makes a difference as to.
Yeah, well, the exclusion, again, this is a hypothetical case, but the exclusion here would just be that the culture came back positive or negative, so it's pretty objective.
So it should be independent of the assignment.
Right. Yes?
What you're bringing up is what we had years ago with the gram-negative trials. We had to randomize patients. We didn't know if they were going to be gram-negative or not. We had to take huge sample sizes, allowing for the fact that some would not be gram-negative, but we would not be allowed to exclude anyone from the primary analysis. And the reason is, and I think you just sent this recently, what this trial is doing is it's testing if we
A
adopt
strategy.
a policy of randomizing before we know this. That is the only question that this trial can answer.
Right.
I don't agree with excluding them, maybe in a discussion section to further confuse people.
Right.
But this is the only question these trials can answer. With randomization helps
Right.
you more at the beginning of the trial than it does at the end.
Right.
I mean, it allows a policy question to be answered, and I think
Yeah.
we're making things too complicated for some of these authors by getting into exclusions.
Well, I mean, we're not saying that they should have excluded, but there was a trial that was similar to this, not exactly like this, and what we got was they didn't tell us anything about these excluded patients. They were talking about only these ones they included in the analysis, and these patients were sort of dead from the report. They didn't say anything about them. So again, it was bringing that back in and talking about so that they could talk about this strategy, not only sort of closer to efficacy of the drug in people that actually had the infection of interest. So again, in Dr. Hernan's article, he talks about methods. Again, we're out of time, but he talks about some very specific methods, talks about how all the methods require data on post-randomization treatment and covariates. So his warning to trialists is to make sure that you continue to collect the data that's going to be able to let you do these sorts of analyses. And this is a table where he talks about the specific analyses that he recommends and some of the situations in which that applies. So anybody who's interested, I think, look at that because we're running out of time. And again, kind of bringing this all together, why this is important. I know that some of you in the room do a lot of systematic reviews, and this becomes important for people who do systematic reviews. So back in August, we published a meta-analysis of SGLT2 inhibitors for type 2 diabetes. And this meta-analysis included 58 trials. The majority of them were comparing to placebo. I think 13 of them were comparing to another anti-diabetes drug. And it was looking at whether or not this drug was efficacious and safe. But the problem was that when it initially came in, they weren't telling us that really when we looked at the trials, a big problem was that there was a high risk of bias because of missing data, and all of these trials used last observation carried forward to analyze this missing data. And then it had another problem where in these trials, which were generally up to like a year long, some of them had post-extensions. And in many of the trials, there was a criteria where after 12 weeks of therapy, if people weren't responding, they got rescue therapy. So you had these people that were getting rescue therapy, and you had to deal with that. And initially, when the systematic review came in, it wasn't. They were kind of ignoring this sloppiness in the trials. So this is kind of what was happening. You randomized these two groups, but after a certain period of time, a lot of people got rescue or no rescue, and then you could analyze them all together, or you could analyze them separately based on that. But really what had been being done in most of these trials, the people were lost to follow-up, they carried the last observation forward, and then many of these trials, the people who got rescue medications were treated as missing, and they carried their last observation forward for that group. So our statistical editors used the opportunity to write a research and reporting method analysis using this systematic review, which in the end, the authors reported risk of bias, and it came out very well, but using it to point out some of the problems in clinical trials and the problems that it creates in systematic reviews when people are not aware of this. This is from that paper by our statisticians, and this shows a patient who discontinued the trial because of an adverse event. You can be pretty sure there that their hemoglobin A1Cs weren't doing well, but they carried them forward. Here, missing because of a rescue medication, so it might be that these people got better, or it might be that these people got worse, but by assuming just last observation carried forward, there is this risk of bias that's created there. And the paper by our statisticians includes a lot of simulations showing what would happen to the outcomes if there was low versus high risk of bias, and what you find out that there really is a lot of variation in the assumptions you make about this drug based on the amount of risk of bias. And so the completion rates in this meta-analysis, the trials varied 69 to 96% with placebo, 81 to 100% with the study drug. The rescue rates 7 to 49% for placebo, 0 to 15% with the rescue drug. And as I reported before, most of the trials just used last observation carried forward, both for the people who were truly missing and the people who got rescued. Okay. So just to the end, the basic message is beware of quick and easy methods.